Welcome to the Neuroveda podcast for complex health. We feature expert guests who dive into ancient and cutting edge technologies of health and disease. These conversations are about food, lifestyle, and medicine just as much as about nature, culture, and politics. I'm Gillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine at our clinic, Neuroveda Health in Seattle, Washington, and I'm pretty excited about our guest today. He is not only brilliant, he's also pretty funny. Very smart. And so Dr. Kiki Chang is a child, adolescent, and adult psychiatrist specializing in mood and neuropsychiatric disorders. He brings 26 years of experience, including creating and running research programs in clinics at Stanford in pediatric, bipolar, and PANS PANDAS. He also provides education to medical professionals, patients, and their families nationally and internationally in the form of lectures, CME presentations, and grand rounds. He's currently in private practice offering consultations, diagnostic evaluation, and treatment for children, adolescents, and adults. His goal is to distill what he has learned during his time in academia into an approach that includes considering psychiatric illness as biological while recognizing psychological input to treatment is important as well. By understanding human brain and psychosocial development and incorporating latest scientific evidence about how the changing environment affects this development, he provides not only a comprehensive diagnosis and treatment plan, but also a plan for returning to healthy development and preventing future disorders. That's right, because time is of the essence with kids, with
Yeah.
developing kids. In addition to clinical practice, he continues to research and consult for organizations such as law firms, pharmaceutical companies, and private foundations. You can email him if you're seeking his services, and you can contact him at his practice, kikichangmd.com. So it's KIKICHANGMD.com. Dr. Chang, thank you for being here. We're so happy to have you.
Thank you. Thank you, Jillian.
I mean,
I appreciate it. I just thank you for inviting me. I actually just spoke to a parents PANS group from Australia. They had
oh,
invited me to come on, and so that's one of my main goals. As I told them last night, was advocacy. Is I'm really all about advocacy and getting the word out and getting the knowledge out. Because people always ask me, "What's the next step in PANS and PANDAS?" And we'll talk about that in a second. But for me, it's advocacy and just getting the word out, and that leads to you know, acceptance, understanding,
yeah.
and funding, and then progression. But so we're still needing a lot of education, advocacy, and yeah, we're trying to light the light in a dark tunnel. So that's
Yeah.
why I'm here. So thank you very much for inviting me. I appreciate it.
Oh, thank you so much. Obviously, you know this, but just to say that you've been such a great mentor and resource over the years with these patients. So you're often available, and I really appreciate it because it's gone a long way for helping a lot of kids.
Yeah,
So
that's
thank
great. I
you.
think people have to be, available for this because there's so much confusion and sometimes misinformation or just lack of resources. So I'm just trying to do that. But I'm only one person. Clearly, there's a lot of people around the world who are doing this now, which is fantastic.
Yeah.
And it's like compared to 10 years ago, it's really grown. So I'm very excited.
Yes. Very true, very true. So and you sit at a really interesting intersection because you're looking at both the biological and the psychosocial. And in kids, that can get really complicated because they're not as well regulated internally and they're not as well trained about, aye, captain, how to behave in a social
Right.
situation. And so it
That's
can be really
right.
challenging. So let's start with like, how can we understand the word neuropsychiatric in terms of the
Mm.
physical and the mental behavior in terms of health and illness? Like, what is neuropsychiatric?
That's a really good question. The way I approach so my background, as you mentioned, is I am a child psychiatrist, right? So that means I went to medical school and learned about the body and Western medicine, and then did my residency in adult psychiatry, and did some internal medicine and neurology. It's all part of the residency, and then specialized in child psychiatry. Went to Stanford to do that, and then stayed there for 20 years on the faculty. And that's when I did that stuff that you mentioned in your intro. Uh, in that time, I basically so I come from a very medical background. I come from a psychiatric background in which we were taught not just biological things, but of course, more psychosocial issues, normal development in children, the effect of trauma and psychosocial stress, and the effect of good parenting, all that good stuff. But I think in the end, I definitely lean towards the fact that I'm a big believer that the brain is a biological construct. I think
Mhm,
there's more to it than that. I think there's something that goes
mhm.
beyond the brain, and what do you call it, the soul or ourselves or whatever. I believe it's there too. But in the end, when we're talking about this stuff, I do focus on the fact that, everything affects our bodies and our brains. And so it's hard to discriminate what's normal and what's not. And when you talk about neuropsychiatric, for me, I draw the line at if it's impeding your functioning, then we're going to
Mhm.
try to change it. So I don't care what's normal. I don't care what's not normal. I see my role as someone to say, hey, you're not living the life you want to live. Your kid's not living the life you want to live. It's causing all these issues. And hey, let's take what we know and let's change it if possible so that you have a better life. So that's all it is. And that's what I say to anyone where you talk about, like, for example, I talk to adolescents or young adults about SSRIs. I'm like, you don't have to take SSRIs. Here's what they do. Here's how good they are, right? You don't have to be completely suicidal or depressed to take them, but you can be. You don't have to be. It's up to you, but here's what I think it's going to do. Here are the risks, here are the cons, here are the pros, and really it's up to you. So I try to provide all the information. So it's hard for me to draw a line between pathology and non-pathology. I try to just say, hey, this is what it is, this is where you are, and this is what I believe can be helpful, whether it's medications or diet or therapy or whatever it is. I'm not sure that's what your question was.
It was,
Okay.
you nailed it.
So neuropsychiatric, yeah, to me, it just I don't know. Yeah, it just means like for me, it's like it means really that you're having some symptoms and we're trying to approach it more from a biological standpoint, more so than a psychosocial standpoint, which I think is really important for what we're going to talk about today because and psychiatry in general, because so many people just say, this is behavior. This is intentional. This is personality. This is this. And so they don't think there's anything biologically that we can do about it. But it all stems from biology, right? It all stems from your
Yeah.
brain. So I always believe there's something we can do about it biologically. I'm not saying that there's other things I'm not saying that, therapy is not going to work and things like that. I'm just talking about, let's not forget about the biology, that it's going to affect everything that we do and it's going to affect all of these symptoms.
Yeah, very well, okay, so then to take it a step further, kids can act so crazy. So how do we distinguish what's normal and what's interruptive to a life?
Right, right, and that's kinda what exactly I was talking about, which is yeah, it helps to know what normal development is. I have so many families that say like, yeah, I these he's 5 years old, I think he's all boy," you know? I'm like, "Okay,
Yeah.
what does that mean? He's all boy." "Well, he never stops moving around, and he can't sit at the table to eat dinner, and he's constantly climbing things and jumping off of it." I'm like, "Okay, that sounds like all boy. Is
Mhm.
that a problem?" You know? It's like, "Well, in kindergarten now, it kinda is." I'm like, "Okay, well, let's talk about that then, let's figure out, is that an issue? Is it not? So rather than just, label it and say, well, he has ADHD and we need to treat it. I could say that and I could go through the whole criteria and say it's a clinical diagnosis. Yeah, there's ADHD. And if you want to, you can treat it or you can do it this way, you can do it this way. But, if we were out in a different environment, it
Mhm.
might not be an issue, right? If we were not in this tight academic environment, if we were not in this area that we live in here, like I live in Palo Alto, California.
Mhm.
You're expected to act in a certain way. So, yeah, yeah, if we were on the savannah somewhere or the jungle or something, it might not
Yeah.
be an issue. Or you might be a shaman, right? If you're like this so creative and always in your own head, thinking about things in a different setting, you might be the leader. And in this setting, you are not paying attention and failing your classes. So I think it's mostly that, okay?
Mhm.
But but at the same time, you're right. It's important to figure out what is considered to be sort of pathological and what is not. I think that's it. Can I give you another example?
Please.
Okay, because remember, you have to stop me because I'll just talk on forever about whatever I want to talk about.
Huh?
Carte blanche. All right. So
Alright,
here's a
we'll do
great
one
example.
more example.
Okay. All right. Thank you. All right. So this is a great example. I talk to parents, not parents, but also doctors, also just other people, just people, and they'll be like, "Oh yeah, they had ticks when they were 3. All of a sudden during the winter,
Mhm.
my daughter developed these ticks, and then they went away. I went to the pediatrician. The pediatrician said, "Oh, that's normal."
Yeah.
I'm like, "Yeah, that's normal. Cancer is normal, right?"
Yeah.
But you're not gonna
Yeah.
like sit there and look at it. I'm not saying it's the same thing as cancer. I'm just saying
Yeah.
everything's normal. It doesn't make it okay. It could
Yeah.
be a sign,
Very
like,
much
where's it
so.
coming from? And that's
Yeah.
definitely a sign, and, like, later on, you find out, "Oh, actually, that was probably the first sign that there was some infection, inflammation in the brain, there was something, and then it resolved and went away, but then it happened again a few years later, and then all of a sudden at age 8, you have, boom, the whole big thing where you had the full PANS PANDAS episode, and then you say, "Oh, well, looking back, that probably was the first sign of it."
Yeah.
I'm not gonna jump on somebody that happened to and say, "Hey, we have to treat it right away and we have to do everything," but it should at least call to mind that, hey, it may not be disease, but there's something going on in the brain that caused that, right? Why is that person having tics? It's gotta be
Yeah.
something happening there, right? And, normal is really hard to say what is normal, so I'm s I'm sorry I can't answer that question better than that.
I mean, I'll say that I think it's part of why PANS PANDAS is a thing that we see is because often PANS and PANDAS is or has a first clear presentation as an acute change.
Right.
Um, I'm sure I'll have a patient whose family will listen to this and they can attest that, the month before symptoms started, she went to Disneyland with a neighbor's family,
Mhm.
with a girlfriend of hers and a neighbor's family at 10, and then she had an upper respiratory, some kind of illness.
Infection, yeah.
And then a month later, she was she had so much separation anxiety, her mom couldn't go leave the house to go to the mailbox. So there's, like, a clear, like, this was normal, and now this is the new
Right.
normal. Very different and horrifying, terrifying.
And still a lot of clinicians will say, "Well, kids get separation anxiety."
Yep.
Kids will
Yeah.
it will happen. Was there something traumatic? You mentioned trauma in your notes, and I was like, was there something traumatic, that happened in
Yeah.
between? Because, did a giant mouse, with black ears come up to you and scare you? Now you have separation anxiety? That would freak me out, by the way. I always thought it was really creepy.
They
It's a
do,
whole right? Because it's like,
but
wait a second, is it normal to have a giant mouse and a giant dog come up to you? That would freak me out. Anyway, I didn't bring my kids
lots
to,
of people love it, lots of people love it. They
I
Yeah,
know, I know, I'm just weird. I didn't bring my kids there until they were, like, 16 and 18. And then I said, "Why didn't I come here earlier? This is fantastic. We had a great time."
yeah, it's a good
Sorry.
time.
What were you talking about? Yeah, did we so I know that your podcast is not just about pans and pandas, right?
Yeah, it's about everything, we talk
About
about
everything.
everything, but
Okay.
yeah,
But today I know that that's the one thing that we were gonna talk about, right? I mean, and so
yeah,
I keep bringing it up, but I keep thinking like, "Okay, should we talk about what it actually is?" And then
yeah, let's talk yeah, yeah. Do you wanna,
Alright.
like, give a
Yeah,
definition?
yeah, yeah, I'm happy to do that. So, I came across this, and I'll do it historically because 'cause it'll be more interesting, I think. So, to me, not to you guys, to me, it'd be more interesting. So, I came across this, I was a pediatric bipolar researcher, as you mentioned, right? So, I was all looking at very early onset pediatric bipolar and looking
Mhm,
at kids who had genetic risk. They had family members, parents, uncles, stuff like that, brothers, siblings who had bipolar disorder and were then ostensibly at risk themselves. And without going into great detail about that, I was following these kids out over time. We were doing brain imaging, genetics, treatment trials, a whole bunch of different things just to try to figure out how can we identify the earliest kinds of things going on. I came across the fact that, wow, inflammation really does seem to be an issue, one of the issues. And then by then, there had been a bunch of people studying it, a lot of coming out of Brazil, looking at adults with bipolar disorder and inflammation. It's hard to know the chicken or the egg because you had mania. Is that why you have inflammation, or did the inflammation cause the mania? And so it's really hard to do that. So we wanted to look early on before the first mood episode, the first depression, the first mania, see if there was inflammation there. Bottom line is that we never did answer that question, but that's moot. But I can't tell you, but I can tell you that I was very interested by inflammation, and coincidentally, at the same time, clinically, started seeing these cases in which I couldn't really explain what was going on. They had mania, they had bipolar by definition, but they weren't responding to typical medications and their course seemed very different. And then when you looked closer, it turned out they had acute onset OCD first and all these other associated comorbidities that don't usually come along with mania, like increased urinary urgency or needing to pee all the time or enuresis, huge anxiety, things like that. So for those kids, I realized, oh, we're probably talking about pans and pandas. And I'd seen a handful of cases before and I knew about pandas and pans. And so I ran across somebody else who was also seeing these kids from a rheumatologic standpoint. And she was seeing kids with OCD and kids with mood problems who had rheumatologic disorders like juvenile arthritis and spondylopathies and things like that. And her name's Jenny Frankovich. And she and I then formed the PANS clinic at Stanford because we realized that's what we were looking at. And not every kid has to have mania. It just happened to be my path to get into this field and get interested in the whole inflammatory kind of standpoint because I realized, you know what? Inflammation in the immune system is behind a lot of stuff. It's not just mania, obviously. It's not just PANS pandas, it's everywhere. And I don't have to tell you that. Yeah, and I'm sure. But cardiovascular disease, cancers, all this, we're talking about inflammation. We're talking about the immune system. Look at long COVID. That really woke up a lot of people to the idea that you could have your immune system go wacky and cause all these neuropsychiatric symptoms. That's been going on for years, hundreds of years. Anyway, but I do think there is an increase now. But let's talk about what exactly pandas is. So I wanted these kids to realize, okay, it does fit. So, pandas, as you know, has to do with strep. Okay, it's pediatric autoimmune neuropsychiatric disorder associated with strep, right? That came out in the 90s. Sue Sweeto, Judy Rappaport were looking at kids who had OCD and realizing a lot of them had acute onset OCD and for a variety of reasons happened after infections or other
So not just Disneyland.
no, no, not just giant mice causing it, right. Seemed like maybe the mice were carrying some kind of illness, some kind of bacteria spreading it to them. And it wasn't just strep, it was everything, but they looked at strep because they knew it was controversial and they wanted to hone in on one specific thing because the research they thought would be stronger, and it's true, it is. Strep is a little different. It's very virulent, it causes very specific problems. We know that from rheumatic fever, right? Valves getting infected, the scarlet fever, the rashes on the body, on the joints, right? All that stuff. So we know that there can trigger an autoimmune response to the entire body, not just the brain, right? But heart valves, skin, joints, and then the brain to cause Sydenham's chorea. So that's been around for years and years. So that's strep. But specifically, they took these kids who had a strep exposure and said, okay, first they have to have acute onset of either OCD or tics, vocal or motor tics. And then in addition to that, they had to have a fairly acute onset of comorbid symptoms like separation anxiety, right? Or depression, or even full mania, or psychosis, or urinary urgency, or changes in handwriting, or regression in behavior. So all of those things are possible. You don't have to have all of them. But the idea was this acuity and comorbidity, which you just don't see in psychiatry. So it's how quickly it comes on and then it hits many things. And so they created the syndrome kind of, diagnostic clinical diagnosis where you had to have those first two things, tics or OCD, and then associated. It had to happen fairly quickly, like over the course of a few days, right? It's not like something happens over years, makes it harder to narrow it down. So, they fought the good fight for many, many years trying to like show that this is a real thing, did a lot of great research, and still caught a lot of flack from a lot of the medical community, really just a few people, but who had a lot of power. And so, without getting into huge politics behind it, it was really tough on Sue Sweeto, and kind of burned out a bit. But then was reinvigorated when I can't remember why. Why did it come about? But they released the PANS criteria. When PANS is now like this is like the early 2000s, right? 2012 is when it was published, but it was realizing that it doesn't have to be strep. And they knew this at the beginning, but they decided to go ahead and throw everything in there and say, you know what? It doesn't have to be strep. It could be any kind of infection or something. It doesn't have to be identified, but it's the acuity and comorbidity. And they changed it because now it's no longer OCD or tics, more politically, because tics were like Tourette's and in the area of pediatric neurologists who disagreed with this the diagnosis, so they're like, "Okay,
Ah,
let's just take it away. Let's call it OCD because that's at least psychiatric." And then eating restriction became a primary diagnostic criteria. So OCD or eating restriction. And again, that was only because over the years they've seen so many people with eating restriction that were really had ARFID, didn't have anorexia classically. Boys, girls, who just stopped eating, and turns out it was really more from like phobias or, fear of emetophobia, fear of throwing up, fear of choking, fear of being poisoned, or just texturally, or just we don't know why. And they would stop
yeah.
eating. So that was important enough that they included that to make sure we didn't miss those kids, right? Because you can see that's kind of a form of OCD. So I put OCD or eating restriction. In addition to that, you had to have at least two of these other neuropsychiatric symptoms, the same stuff as pandas. And it had to happen fairly acutely. Again, what is fairly acutely? When we got together, we said it was like 3 days. When I say we got together, we had a conference at Stanford and we brought everyone in who was researching the stuff at the time and we came up with our diagnostic kind of like agreements, expert consensus diagnostic agreements,
Mhm.
clinical workup and treatment. That all got published in 2015 and 2017. But basically, it had to be that acuity, which was open to interpretation, and it had to have that comorbidity. So it doesn't look like anything else. That's the whole point. It's like, that's not how OCD comes on. That's not how Tourette's comes on, all right?
Yeah.
Yeah, so
And
the problem was, what if you already had a little bit of OCD, right? What if you had some tics already? What if you had autism and you tended to have OCD and you had some tics or stereotypies anyway? You can still. In fact, you're probably more likely to because you're already geared to go that direction. You throw a little inflammation into the basal ganglia, and next thing you know, boom, you're off to the races, PANS
Yep.
flare. So, but the problem was that then it becomes harder to separate. Is that the autism? Is that the Tourette's? Is that, and so a lot of clinics, including Stanford, said, "No, you know what? You gotta just focus on the very pure phenotype, right? Just that you were fine one day, the next day you weren't, because that's gonna at least get the right kids. By right, I mean like for study, for research study, and it will be less, controversy when you have other doctors saying, "Well, you're, just we're having Tourette's people in there, and you're having this, and you're no, we're having this very clear cut group of kids, but then that ignores all these other kids that are sort of on the spectrum of PANS. They're definitely out there, and I won't go into that because 'cause I'm talking nonstop.
that's why you're the guest.
That's why I do this because my kids and my wife, they just tune out after about 5 minutes. So, you can't tune out because you asked me to be here.
No, well, and I'm also very I mean, I asked you to
Yeah,
hear
no, no,
because
no. Plus, you're not related to me, so you don't have to hear this all the time. So
well, and it's a really interesting story because I think, just like with the disease itself, where you're really overlapping the biology with the psychosocial, when you look at the natural history of the diagnosis, the
yeah,
diagnosis is kind of putting together the characteristics of what is already in reality. Something can be in reality if before it has a diagnosis, it still exists. And so the diagnosis is what gives it kind of the shape, the structure, the name, but it's fascinating to hear your story because we can really see how medicine has had to change over time, and that's part of how medicine evolves. We need that and we want that, but, there can be there can be a
mhm.
lot of feelings even in this.
Big feelings. People can have big feelings when you step on their toes, and they've been wedded to the idea that PANDAS doesn't exist, or this is
Yeah,
all Tourette's, or this is a functional neurologic disorder, or things like
yeah,
that. It's a problem, and unfortunately, those big feelings have led to these controversy. I'm doing air quotes for those of you who can't see me. Controversy like, "Oh, does it exist?" No, it's no controversy. This stuff's been around forever. It exists. Don't be ridiculous. The fact that it took the American Academy of Pediatrics, like, 30 years,
yeah,
Sue was trying to get them to acknowledge pandas, and they never did. It doesn't
yeah,
have a no diagnostic code, in the DSM-5 or ICD, it's like, we don't even have a code. Why is that, And it's largely political, and that's so weird because 'cause I'm like, "Why? Why?" But I don't have to tell you, like, look at today's state of the union, so to speak, everything's political, and
yeah,
when it becomes that way, then that's when science suffers, right?
yeah.
Because now you have this other thing on top of it, which is like, "What? No, 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 let's just help people." Anyway, yeah, 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 so I don't have to sit go they took them 30 years to recognize it. They came out with a white paper last year, the American Academy of Pediatrics.
That's
If you
weird.
read it, it's like, "What? No." They said they contacted all these experts, right, for their white paper. I was on
Mhm.
a call with, like, 30 of us who do research and see patients, and only one of them had been contacted about it.
Wow.
And that person I'd never even heard of. So, it's like, "No, you didn't contact the experts, you didn't get anything," and in the end, this is what they said. They said, "There's not enough evidence to support like immunomodulation," right? Like like, just like not saying it doesn't work, but there's not enough evidence, and I get what they're saying. There's not enough evidence, out there published. We need a lot more studies, but there's expert consensus, and there's a lot of open studies, and there's a lot of immunologic treatments sorry, rheumatologic disorders that are treated with IVIG that don't have a lot of studies showing that, it works versus placebo. It's hard to do those studies. Anyway, but there are studies coming out, and yes, we will prove it. But then they said, so what we're recommending is the first line treatment for OCD, which is CBT and SSRIs. If you read the white paper, that's what it says. And you're like,
Wow.
what? Why would you say that? Is there any evidence for CBT and SSRIs to work better than placebo in kids with PANDAS or PANS? No,
My goodness.
no. If there were, then you would say, yeah. For OCD, yes, but that's different. We're not talking about just, regular OCD. This is not regular OCD. So what they're doing is very dangerous because those of us who treat
Yeah.
kids realize that if you give kids SSRIs in the middle of a acute flare, I'd say about 70, 80% of the time they get worse.
Yeah.
Fact, some of them even get fully manic, and I've seen that many, many, many times. So I have no doubt it's true. Unfortunately, we don't have the studies again that are, you know,
Yeah.
placebo controlled, right? That's what we should do. We
Yeah.
shouldn't, 'cause I think there'll be a lot of kids who suffer, but ideally you would do that just to prove, no, it doesn't work better than placebo, it works worse than placebo. But I can't even take now CBT. There is a study on that, but it's not in acute flares. And CBT and ERP can, these are therapeutic modalities that can be very helpful for kids with OCD, not during an acute flare, and you talk to any therapist that's tried to work with these kids in acute flare, they'll say the same thing. It's not possible. It's not
Yeah.
possible. To wait till it comes down if they have residual symptoms, and yeah, that makes sense. ERP, space therapy, CBT, all could be very helpful, but not at the outset. Not at the outset. So,
Let's talk about like what a comprehensive workup looks like.
yeah, yeah.
And what do patients I mean, we've talked a little bit about the OCD and tics and post-infectious and the separation anxiety, so kind of the big feelings piece and the time course. Are there any other ways that you've had patients present to you besides the kind of that pantheon of symptoms?
Yeah, yeah. So that's a good question. I think, like I said at the beginning, that the mania stuff was really huge, right, for me. But that's not usual.
Mhm.
But it's not unusual because so many of these kids will also have big rage attacks. It may not be full mania, but it's pretty much mood dysregulation. That's the euphemism I like to put down in their charts. Again, there's no diagnosis of that in the ICD or in the DSM, but it's mood dysregulation because they are suddenly flaring and becoming hugely violent or irritable or destroying property or attacking people or, grabbing knives. Okay, now I'm gonna go on my tangent. There's this great paper from 100 years ago from JAMA. I think it was JAMA. Yeah,
Really?
Journal of American Academy. Okay, 100 years ago, and it was about kids with Sydenham's chorea, basically. They got strep and they had choreic movements, but it was describing all the associated symptoms, and they were listing and this is a slide I got from Jenny Frankovich. So they were listing, just the different symptoms that these kids were having. It reads I mean, it's sad, but it's funny at the same time. It reads
Mhm.
like, "Okay, boy number 11 tried to, kill his brother with a shovel. Boy number 6, attacked his mother with, like, with knives," or something like that. It's like,
Uh,
this was 100 years ago. This is
oh my goodness.
1920s. And I'm like, "Oh, yeah, we have that now too," right? And yeah,
Shovels and knives and everything.
absolutely, and doesn't mean that that's diagnostic of a PANS flare, you have to get everything else, but they'll present with that, right? Rage, anger attacks, and then you, like, look underneath, and a lot of times it's the OCD, dysregulation, and rigidity, and when something doesn't go exactly the right way, or the OCD gets interrupted, or they're not allowed to do something and they really need to do it right now, then that's when the mood can explode, and if you have that combination of brain chemistry, then you can get towards those huge rage attacks. So rage attacks very commonly. Which is interesting, Jillian, because you can
Mhm.
interrupt me if you want. Because when I first got into bipolar disorder research, there was a lot of these kids having rage attacks. And it was controversial back then because they're like, you're just over medicating kids. These are temper tantrums, right? Well, I agree. And kids got overdiagnosed with bipolar actually in the late 90s, early 2000s, I believe, because they were having rage attacks. And looking back now, I wonder how many of them
Yeah.
not all of them
Influence.
had PANS or PANS, but I wonder how many of them did. Some of them had bipolar, some of them just had other reasons for their anger attacks, for sure. But again, it's similar. In bipolar, you gotta go back and say, "Well, take hold on, you can have a rage attack, but did you have a decreased sleep? Did you have racing thoughts? Did you have, like, very impulsive behaviors? Did you have, any kind of hypersexuality? Did you have these things, et cetera, et cetera?" And same thing, it's a syndrome, you put it all together, and if you fit that, there's enough research to show that that's really mania, that's really it. And if you don't fit it at all, then you're like, "That's probably not mania." If you have 2 or 3, you're like, it could be." The brain
Mhm.
doesn't say, "I'm gonna become manic, I'm gonna not become manic." It helps if it's full mania, but if it's not, it could be in between or it could be something. So you have to see all these gray areas, but still use a framework or else we're not talking about the same thing at all. So that's the same thing with PANS, PANDAS. You gotta use that framework. You're talking about the same thing, but you gotta realize there's some spectrum going on there. So anyway, so rage attacks, presenting with that, the OCD, presenting with that is very common, obviously, tics, the eating restriction, as I mentioned. A lot of people on these eating disorder wards who are not responding to treatment were realizing, oh, they might actually have a form of PANS and PANDAS. Now, same thing with bipolar in the 90s. You can overdiagnose PANS and PANDAS as well. And that's
Mhm.
usually the case with anything, right? At the beginning, when people catch wind, especially parents, and I love parents because I am one, and I think all
Mhm.
parents are wonderful because I am one. Anyway, for sure, like, hey, this is what's going on. This is what's happening with my kid. I'm gonna take them to somebody who's gonna diagnose them bipolar. I'm gonna take them to somebody who's diagnosed them PANS and PANDAS, and we're gonna go that way. I can tell you I have seen the overdiagnosis with bipolar for sure. I've seen the overdiagnosis with PANS and PANDAS. It's from trying to help and trying to find an answer. And sometimes you're in the spectrum, so it's okay. But then if you're not, then I have to go back and say, well, actually, I think it's this, because then you're not gonna have the same kind of treatments at all. Of course, that's why you got to have a pretty good diagnosis, or at least be somewhere in the ballpark. What were we talking about?
So, what kind of the clinical presentation, like
Yeah,
when patients come, and it's really interesting to hear because it is true that if you don't know anything about this syndrome, then it's hard to think that this might be it versus something like bipolar or behavioral. And if you know all about the syndrome, then it's kind of like you want this to be the solution rather than
right,
something
right. Or
environmental
not knowing.
or
Right,
yeah.
right, or not knowing, yeah, exactly. It's hard to, but, it's important for people to say, "I don't know." Not that, like, this doesn't exist or
Yeah.
this is not it. Just say, "I'm not really sure. Let's find
Yeah.
somebody who might know," you know?
So then what do you do? So someone comes in, what are your
Mhm,
kind of initial tests like in terms of biomarkers or
sure.
imaging or physical
Yeah.
exam? What are you doing in clinic?
And again, just like I mentioned before, there's no biological marker that's gonna diagnose it, there's no one thing. It's a syndrome. It's a collection of symptoms, just like depression is, just like mania is, right?
Mm.
It's a syndrome that we've collected through observation and saying, "This is different," and then we've studied it, and then we say, "Yeah, this syndrome actually does have some unique features of X, Y, and Z," and there's a whole area of study that talks about how something has to become a diagnosis and what makes it a I won't get into that, but it has to do with responding to specific treatment, having biomarkers, having consistent X, Y, and Z. So whatever. We do fit that. But basically when somebody comes there and there's no marker, but so first you got to get a really good clinical history. And it's not very sexy to say that, but that's the same thing for most of psychiatry. That's what you got to do. It's
Yeah.
amazing. It's amazing you could do that. And if you get it good enough, you can make these diagnoses. It's amazing. You don't need to do a physical exam. You don't need to do any kind of laboratory work. You can really, really do that. Now, the physical exam will help.
Mhm.
The logical exam will help if you know what you're looking for, right? And the rheumatologic exam would be great. I don't do that because I'm not a rheumatologist, but my colleagues will. And the Stanford clinic, Jenny Frankovich is still running it. I left 8 years ago to go into private practice. And, we started together, also with Margot Tiedemann, who's a great child psychiatrist. And we were in the trenches kind of figuring all this out together, which is great. And that's what I think it's important to remember, is that to make it sometimes is really important to have those different eyes on them. Yeah, if you do a comprehensive history, you can do it, but who knows exactly how to do that, right? Well, psychiatrically, you kinda know, if you're trained correctly, if you're a psychiatrist or a mental health professional or whatever, what to look for, and so you'll do that, especially in kids, if you're a child one. But what about asking about, the pains and the arthritides and what's normal from this X, Y, and Z? So the medical part is super important too, and I had to learn that, and I learned all that from Dr. Frankovich and colleagues and myself, and years and years of just doing this. So ideally, you would be able to have both a medical person and a psychiatric person in the room at the same time doing a diagnosis. That's what we did. Yeah, it was
Yeah.
both of us, in the room for an hour, if not an hour and a
Wow.
half, not
Wow.
longer, really trying to break it down because we were at the beginning and trying to figure this out. And then she would rely on my knowledge of, "No, this is not this is not typical OCD, this is not this," and I would rely on her, physical exam and medication and history and illness history and what's normal from that, and we would put it together, and it was super, super helpful. Now, not
That's
every
it's amazing to consider 2 clinicians for an hour because one of the things about kids is that they don't have a lot of years to talk about. Isn't like, you're not doing 70 years of history. You're
Oh,
not even doing, like, 25 years of history,
right, right,
Yeah.
but it tells you about the details that you can get in
Yeah.
those 10 years of history. It's quite amazing, yeah.
Ah, amazing.
Yeah, no, you're right, and is so you gotta dive down into that, but you're right, not people out there, they don't have access to these kinds of clinics. In fact, there's
Yeah.
not very many clinics like that anywhere. In fact, it's very
Yeah.
rare. So, when we did it, we were the first of its kind, right, to say, "Hey, let's do that," because it's also cost prohibitive, right? Who's gonna pay for 2, you know, different doctors at the same time to look at somebody? That never happens, right?
Yeah.
But it should
Yeah.
happen. It should
It
happen, but
should. It
yeah,
should.
with our medical model, it doesn't happen.
Nope.
So then you have, like, people with their own silos looking at something from their angles. Yeah, that's fine, but you really need either
Yeah.
someone who's seen it all or somebody who or multiple people. But still, I still believe at least if you come from a psychiatric background, a pediatric anyone can learn this stuff, right? Like, it's not I mean, I am brilliant, right? I am a genius, but other people can do this as well too, you know?
Mere mortals have the capacity.
Exactly. No, no, that's what I'm trying to say is I'm not. And, like, all you gotta do is have common sense and learn it and be open-minded and just, you can anyone can learn to do this, kind of thing. So, anyway,
And you did
so
I wanted to just add one point, you talked about there not being biomarkers for,
yeah,
PANS, PANDAS. There's certainly biomarkers you would wanna rule out, like, thyroid,
absolutely.
things like
Uh,
okay, and
yep,
then one other question, I'm
yeah.
curious what weight you put on something like ASO or DNA speed, the DNA yeah.
Yeah,
Can you
sure, absolutely. We will do a full a full lab so having said that, I will definitely get a lot of blood and drain it all and we'll say, "Ooh, sorry," but, hydrate, and we'll get it all and look at a lot of things because you wanna look mostly, what this will do then is figure out the cause, okay? Not whether or not you have it, but if we can identify a cause. And I have to say the first round of blood work, about half the kids I do it at least on, is completely normal, so it
Mhm,
doesn't help us. The other
mhm,
half, we might pick up something like you mentioned, strep antibody titers, right? So titers, the ASO is an antibody against streptolysin O, which is an enzyme on the strep molecule or bacteria, I should say. And DNase-B similar, right? So those are 2 things that we get, and yeah, if they're really elevated, then we say, "Huh, you have very elevated strep titers." Do It doesn't mean you have an active strep infection. It could. You coulda had one a month ago, right? But again, the clinical stuff is so important. If you're like, "Yeah, I had a sore throat a week ago and a fever. I just didn't we didn't check it out. We didn't get the swab. We should have." Yeah, you should have, but it's not too late. You can still swab.
mhm,
But we do get throat swabs, for that. We do get blood markers, mycoplasma, Epstein-Barr, viral stuff, bacterial stuff, basic stuff. We get Lyme antibody, basic stuff, all right, just to make sure we're not missing anything. But even if it pops up, it just usually means that you have that antibody. It doesn't mean you have that infection. We don't even know if that's causing the problem. So, having said that, it does help guide us because if you have the clinical piece of a strep infection and you see the titers are high, then yeah, no brainer. Let's go ahead and treat that with antibiotics because why not? Not that we want to create treatment resistant bacteria, but it's such low hanging fruit that if you can do that for a good now, I usually do it for more than 10 days. Most people do up to 14 to 21 days actually with a good
mhm,
antibiotic, right?
mhm.
Could totally these kids really can get better. Like totally, like 100%. It's crazy. Who treats OCD and ticks with antibiotics, right? Nobody until now. Then
Yeah.
we realized actually you can completely reverse it. So that's why we do get those. It's more for treatment and cause, right? We know that it's likely an inflammatory condition. We know that the immune system is whacking out for some reason.
Uh-huh.
That's
That's the
official
technical
medical
term.
speech. Yeah, yeah, yeah. That's whacking out response and staying inflamed. And we believe, at least in the case of PANS, PANDAS may be a little different. What I won't go into that, but PANS itself, probably there's some sort of inflammatory thing going across the blood-brain barrier and affecting the basal ganglia. And we have imaging data suggesting that, right? A lot. I won't go into details about that again, but lots of imaging data that indirectly show that, yeah, there's inflammation there, and yeah, there are neuronal cells that are activated, microglia that are
Yeah.
when they're inflamed, they get activated and things like that. So then there's the next step, which is we say, well, then it makes sense in the basal ganglia, which is the switchboard for the brain, right? It's a fine tuner of all these different circuits, the motor circuits, the mood circuits, anxiety circuits, focus circuits. It makes sense that if you knock out that with inflammation or something else, then you're knocking out these circuits and then you're getting these symptoms, many different symptoms. That's the comorbidity. Right?
Mhm.
Not like encephalitis where your whole brain is inflamed and you're knocking yourself out and you're having seizures, right? You're still conscious, you're still you. It's just this fine tuning is going off. And so that's why people can think it's behavioral or, personality or function.
Oh.
My favorite, functional neurologic disorder, which used to be called conversion disorder,
Yeah.
which means you have a psychological thing causing these symptoms. Now that can happen. But again, this kid has no other than the giant mouse traumatizing you, there's no other reason that after Disneyland, you should really have that experience, right? So
Yeah.
it's like, well, what good does it do? There's no secondary gain, there's no primary gain. Doesn't make any sense. Like, why should you suddenly not be able to walk and all this stuff? So anyway, that disruption of the basal ganglia, I think, is really important to understand that that's probably what's going on. That's what we're looking for. We're not going to see that on brain imaging, unfortunately.
Yeah.
I would love to get brain imaging on everyone, just a basic MRI, just to make sure nothing else is going on, right? Like, anything else going on medically with the brain. Would love to get an LP, right? A spinal tap, lumbar puncture. Just love to get just to make sure
Mhm.
90% of the time we get them, they're completely normal. All right. Same with the MRIs, but that's okay. MRIs,
And
you
you
can't see inflammation acutely, unfortunately. You can't.
Yeah. What about is there any do you see or foresee any usefulness with like a spec scan or PET scans upcoming?
Yeah. No, just because with PET scans, it's so hard to do in kids and the radiation and stuff like that. I used to wanna be a PET scanner, but I ended up doing functional MRI and MRI instead at Stanford because I was like, "Oh, yeah, no, I don't wanna put central lines in kids and give them radiation."
Yeah. Yeah.
Anyway, so and they're fuzzy. They're super fuzzy. Same with SPECT scans, super fuzzy, hard to tell what's going on.
Okay.
fMRI is a lot better, MRI is a lot better. Even with those things, we can't make a clinical diagnosis of anything that's psychiatric, other than maybe early onset Alzheimer's with PET scanning and things like that at this point.
Yeah.
So
Parkin
it's not ready for prime time. There's a lot of private clinics that do it. They have their own protocols, but in general, no, it's really
think it's
not
worth
research. Yeah, it's not really worth it, and usually it's not worth it. I mean,
is
sometimes
that
patterns and they can say like, "Oh, that's a pattern that responds to this medication. I've seen that before," and it works. That's
okay.
okay, but it's not very specific.
And so there's really no kind of technical way to confirm kind of psychiatric from basal ganglion infection.
Really tough. Other than clinical and here's one thing though, obviously if the LP does show like some autoimmune antibodies, which you send it off to the Mayo Clinic, then you're like, "Oh, this is kind of like an autoimmune encephalitis," and then that's different, right? And then people start going, "Oh, that's an autoimmune encephalitis. You have a finding. Let's treat it. Let's give steroids IV. Let's give out, whatever." That's great. The insurance companies will have to be forced to cover it, right? But if you don't have it, then you got to fight and say this is what we call seronegative encephalitis. In other words, we don't have the antibody. We don't have proof that it's going to the brain, but look, we think it is. Okay. So
Uh-huh.
unfortunately, you know. Anyway, so yeah, but there is one thing like, okay, here's the thing. You may have heard of the Cunningham panel. It's now called the autoimmune brain panel.
Mhm,
It's by folks at Moleculaira. I don't have
mhm,
any stock in them or anything like that.
mhm,
I do know them personally and they're wonderful people, but you know, it's again that controversial thing, which is like some people say, "Oh yeah, it's really good," and other people say, "No, it's totally useless." Well, I think the truth is somewhere in between. Right?
mhm,
It's a good test, but you got to know how to interpret it, and you can't overinterpret it. And
mhm,
there's enough published out there about the test that you can make your own decisions. So
mm,
I get it once in a while, and it looks at 4 different it's the blood markers. So you're looking at 4 different autoantibodies against neuronal things, right? Dopamine receptors, isoganglioside tubulin, but so these are antibodies against that, and you're looking at that in the blood, not in the
mm,
brain, but in the blood, not in the CSF. So, it's still a good indicator of what might be in the CSF. But that's not the interesting part because that part to me is like, yeah, they can be high, but it's not specific. And we all have autoantibodies to our brains and everywhere.
mm,
It's just low levels. And but so I haven't been too impressed by that. But yeah, there are some things that sometimes if they are really high, then you kind of go, whoa, that's definitely something. But it's the last thing on that test that I really like, which is the CAM kinase 2 enzyme activity level. This
mm,
is interesting because they put it in with the patient's own antibodies, right? They isolate the antibodies and put it through there, and it speeds up this enzyme and it makes it more active if you have PANS or PANDAS compared to kids who don't. And it's like, what's going on with your immune system and this enzyme? And this is fascinating because incidentally, I'm also on the board of the CAM kinase 2 mutation group, which looks at these rare genetic mutations in kids in this enzyme that gives them these neuropsychiatric conditions. And I came across this through a patient of mine a long time ago. And since then, I've seen a bunch of patients with this enzymatic mutation. And
mhm,
they don't look exactly like PANS and PANDAS kids, but they
mhm,
have some similarities, and it's really
mhm,
interesting. Now, the treatment is different, right? Because this is the enzyme going. You're not gonna, like, throw antibiotics and things like that, but
mhm,
see some of the same neuropsychiatric symptoms. You can see some episodicity to it. It's really interesting. So, this is an important enzyme that if you
mhm,
knock it out or disrupt it, it can
mhm,
lead to these neuropsychiatric changes, and in this case, in the case of this Cunningham panel test, that if it is elevated, it's the one that I do, again, tend to see above a certain level, like 140, 150, more than they recommend. But for me, if it is up there, then it does support at least that your immune system is involved, it's jacked up, whacked up, and then you may be a better response to immunomodulation like steroids or IV.
Okay. Fascinating. What about some of the other neuromarkers that we sometimes see, like neurofilament light chains or MMP9 or VEGF?
Yeah,
Any of
the
those?
matrix proteins and things like that, yeah. I
Yeah,
think those are really early. Yeah, metallic matrix protein, those are really early. So I don't know, whenever I see something like that, I look it up and I go, "Oh, that makes sense." But I just don't
uh-huh.
know. I don't have enough, evidence on it, so I tend to stick with just some basic things. Things like SB100, that's like a
Oh, yeah.
protein that can also be related to blood-brain barrier, leaking,
Yeah.
which
Yeah.
has to happen in order for this to happen. That's a
Mhm.
great thing too. I've seen people who check it, but I never check it because again, I just don't think there's enough yet to say, "Oh, this helps me understand what to do next." If I understood what to do next about it, then I would. But for me, that one test does seem to correlate with a good response to steroids or IVIG. So that
Okay.
kind of that's when I'll get that when I can't find anything else, I'm not sure which way to go, I might get that. But the other tests are fantastic, right? For infections. If it looks like you might have an infection, you gotta chase it down, but a lot of times kids don't make antibodies. Some kids just don't make DNase B or strep antibodies, and they'll have strep
Mhm.
infections.
Yeah.
So that's, like, great. And mycoplasma, don't get me started on mycoplasma. So often we just talked
Mm.
about this week on another call. So often we see the IgM elevated, which is the acute,
Yeah.
antibody that would suggest that you have an active or recent mycoplasma infection. The kid's not coughing, there's no fever, there's no walking pneumonia, there's
Yeah.
nothing. It's really high, and so there's some issues with that because that test itself can be falsely positive, so you have to
Okay.
get, immunofluorescence to really kinda say, "Okay, this is exactly what we're looking at, it's not cross-reacting with something else." But it could also just be an activation of that antibody that you've had exposure to. Again, if your immune system is whacked up, right,
Mhm.
that you might just be pumping out that antibody. Same with Epstein-Barr. We see a big what they call reactivation of Epstein-Barr. Well, is it really, or is it just because it's just the IgG all of a sudden going through the roof. It's not the
Yeah.
IgM. And you're like, is that really a reactivation of the virus, or is it your body just pumping out more IgG of stuff that you've seen before? I
Yeah.
It's hard to answer that question. I'm more of the latter camp, but, because those things tend to improve and get better when you do immunomodulation. It's not like we need to treat those things necessarily.
Do you ever see chronic infection being the root of this, or is it
Ah.
mostly like neuroimmune, like
Right,
cascades?
right, right.
Uh,
I mean, that's the tough one, right? Especially the tick-borne illness one, that's really tough area, right?
yeah.
Because just because something comes up maybe positive, how do you know it's actually causing the issues, you know? So, a lot of times I understand that. I understand, like I mentioned, that parents will try to figure out what's going on or doctors try to figure out what's going on, and then I usually say if you go that direction and you're trying and it's not helping with all the antibiotics and other things designed to kill chronic infection, well, stop trying eventually and let's start immunomodulation. No, even Lyme docs will use IVIG, right, at some point because we
Yeah.
know most of the time it's not just the bug, it's your body's reaction, just like COVID, right? It's not COVID that's killing you, it's your reaction to it. It's
Yeah.
your immune system. It's our immune systems have not continued to evolve correctly. They're overactive and they've evolved in the wrong way. So
Yeah.
now it's like it can be our biggest enemy.
Yep.
And that's what it is. So immunomodulation still has a lot of, potential. Can't I'm such a huge fan of steroids. I know you wrote that down. I hate to say this because, it's not, like, fantastic, but, I mean, gosh, there's just so many examples of conditions that, "Oh, suddenly we use steroids and you're so much better," right? Whether it's asthma attacks or whether it's poison oak or whether it's PANS or PANDAS or whether
Yeah.
it's an autoimmune encephalitis. There was a story in the New Yorker just maybe last year, and I'm
Mhm.
trying to remember, it was a really good article, and it was a woman who had, mystery diagnoses things, right? No one could figure
Yeah, I
out what
love
it
that.
was, right?
Yeah.
And all of a sudden she gets steroids and she's, like, back 100%, and she's like, "Oh
Yep.
my god," but then you can't keep taking them, so that's when you talk
Mm.
about other things. But I'm
Yeah.
like the whole time I started reading that article, I'm like, "Oh, no, she needs steroids. Give her steroids. Give her steroids. Give her steroids."
Get her. Yeah. Yes.
And the New Yorker, some of their articles, I don't know if you ever read,
Mhm.
way too long, right? Who's got time to read a 10-page article? I don't. Great writing, but you're killing it. You're just beating it to death. Let's just cut it in half. Anyway, what was I talking about? Yeah, so there you go. Steroids are fantastic. NSAIDs, wow. What about that? Curing OCD with ibuprofen, right?
Yeah.
Sounds totally fantastical. I've seen it happen multiple times. Usually it's not that simple, but hey, low hanging fruit. Again, what's the problem? Just try it for a week, right? Try it for 2 weeks, see if it helps. Yeah. That
Yeah.
one's not going to be a problem, right? Antibiotics, I can see why it's a little bit of a problem. I don't use them willy nilly. I use them when I think there's an infection, but a lot of these antibiotics are really good anti-inflammatories, right? So they could work, but they're not killing anything. They're just working on the inflammation. In fact, most of the time, that's probably what it is.
Mhm.
Augmentin, azithromycin are fantastic anti-inflammatory
Mhm.
medications. So you got to be careful because once you start doing that, you take them off, they get worse. You're like, oh, we got to put them back on again. Then they're on antibiotics for years. Now, that's an issue. I do have some kids who take them chronically, but I try not to. Most
Yeah.
do not. Prophylactically is different. If you have to prevent strep from happening again, that's super important. You got to prevent that. So low dose prophylaxis, that's different. So low
When
hanging.
when you think about low dose prophylaxis, what does that look like for you? Like, would you keep a kid on a low dose ongoing or just with like if they're going on a flight or starting school?
It
If you
depends on what the issue is. As I mentioned, if they've had multiple strep things and it just looks bad, then yeah, they'll stay on a low dose like some cephalosporin or something like that every
Okay.
other day or just a low dose. Sometimes it's just through the time of risk, through the fall and the winter, we'll
Yeah.
do that. And sometimes it is through when kids get things like dental care, right?
Mhm.
They go to a dentist and stuff like that. All the time you hear about that causing little flares, and so we'll be like, "Well, what about giving a little antibiotic?" They'll do that anyway, right? If you ask them,
Yeah.
the dentist will, and so give for 2 days before and 2
Yeah.
days after, and that's fine. It seems to help really prevent those kind of things. So I'll do that. Yeah, those kind of things mostly.
And then
Usually
what about
that go ahead. What about what?
well, I was gonna say, what about other immunomodulatory things, like some of the more, like, hippie things or what I think of as that,
Yeah.
like low dose naltrexone,
Yeah, you got you hippie people out there. I'm coming from the hippie capital as well too, as far as
You are,
California,
yeah.
Northern
So yeah,
California, so
yeah.
no, no, exactly, right? I wish there was so many more, studies on that, but do I see kids taking that low dose naltrexone? Yes, all the time. Do I
Uh-huh.
think it helps? I think in some cases it is helpful. I rarely see it as because I see, these very severe cases, or I see moderate to severe cases usually, and
Yeah,
so LDN is, for me, at that point when they're flaring, kind of a drop in the bucket, right?
yeah.
Compared to, like, steroids, right, which is
Oh,
overkill,
yeah.
but at least, hey, you're gonna get it down quickly. But I do see a role for more of, and it's funny that you say hippie stuff, but, of those things more chronically, more long-term, more preventatively.
Mhm.
That's when I talk to parents about diet and anti-inflammatories and omega-3s and turmeric, and possibly things like that, as far as the microbiome in the gut, yeah, I'm sure there's a story there. I just don't know exactly what to say about it. I'm like, "Well, just give a nice prebiotic, probiotic." Juliet Madan at, Dartmouth, a great PANS child psychiatrist, is studying the microbiome, so I keep telling her to hurry up and tell us what to do because I don't know what to do. But, there's a lot of people who are trying to do it anyway, which I think is very noble, but I still
Yes.
don't really have the guidance, so I don't feel comfortable doing that, but I say, "Go see somebody else."
Yeah,
Probably like yourself, I'm gonna say, Jillian, or who knows more about that than I do. I just wish there was more out there, but I do believe, I have prescribed LDN to some people. I do believe in its anti-inflammatory properties. I read the papers and whatnot. So again, anyone can read the papers and understand this and try to figure out what the side effects are, what the risks are. Yeah, it helps if you have a medical background to make sure you're not killing the kidneys, that you're not interacting with other
yep,
medications.
yep,
Nowadays with, like, AI, you can just kind of put that in there and check it out,
yeah,
and
yeah,
grain of salt because AI will still make up things out of the blue medically,
yep,
so be careful, right? It will tell you
yep,
that you have cancer when it seems like you just have a vitamin D deficiency or something, so
yeah,
you gotta be careful, but it's a good start, and, it can help you kind of narrow down things, so, uh
yeah. Are there any other treatments or interventions that you can think of that we haven't quite talked about?
Well, absolutely, we haven't gotten towards, let's see, we talked about NSAIDs, so, my way to look at treatment is like, this is inflammation, but where's it coming from? If it's infection, go with antibiotics. If it's not, go with NSAIDs and anti-inflammatories, and then, immunomodulators if you need to change that. Immunomodulators is a whole 'nother thing, right? That goes to IVIG, methotrexate, rituximab, and now folks at Stanford, Patrick Whelan at UCLA, they're rheumatologists, and so
Mhm.
they're using these disease-modifying anti-rheumatic drugs, DMARDs they call them, right? Things like
Yep.
leflunomide, sulfasalazine, they used for years. Now the new biologic ones. right?
Yeah.
TNF alpha inhibitors, things like that, Humira, Rinvoq,
Yeah.
and seeing like, hey, if we can stop the inflammation that way, modulate the immune system that way, not only will we address these either micro or macro arthritic findings that they're finding in these kids, because it's not just inflammation in one part of the brain, right? It's the whole body. But that also their neuropsychiatric symptoms improve. To me, I haven't seen enough kids improve on that to say like, "Oh yeah, Humira works for OCD." I haven't seen that yet. I haven't had too many kids on the biologics. I've only had a few that I don't prescribe myself, but I've only had a few who've been taking them. So it's too early for me to figure that out. I do know the folks at Stanford are very interested in pursuing that, but again, we need the placebo-controlled trials. We need studies. We need funding. We need all of that
Yeah.
good.
And so let's kind of transition into research. What are your favorite do you have some favorite research organizations?
I do. It used to be me, but now that I'm no longer there, I direct people towards Stanford, right? Because of
Okay.
course, towards Jenny Frankovich Clinic, they have great people there, but their research they're doing is fantastic because they're just, oh my god, it's amazing. And it's
Mhm.
not, I would like to take credit for setting setting the foundation for that, but they've gone way past anything that I was doing because I was the research director originally.
Yeah.
Uh, the stuff that they're doing is really cool. Looking at, not just genomics, but
Mhm.
proteomics,
Mhm.
genomics, and things like that, as well as, like I said, the anti-rheumatologic drugs, or the rheumatologic drugs, I should say, and things like that. So they're fantastic. I mentioned Juliet Madonna in Dartmouth, doing the microbiome research. I'm a really big fan of that. But also worldwide, European. I'm on the EXPAND board, which is the European Advocacy and Research Board for PANS PANDAS. Why am
Interest
I in a European one? That's a good question, but I am, and I love it. And because I might move there. No, but yeah, no, they're fantastic. And they have a lot of good researchers out there doing things. I'm excited about Russell Dale's work in Sydney in Australia,
Mhm.
because he's coming at it from an autoimmune encephalitis standpoint. They have a very different viewpoint and looking at different ways of modulating the brain and helping
Mhm.
it. I'm excited about that. Yeah. Yeah, yeah, yeah. And I'm just jealous because I wish I were doing it on one hand because I miss the actual research,
Mhm.
but I don't because I know how hard it is to get funding. And I
Yeah.
left before the current administration and before the huge cut in funding. And I talked to my colleagues too who are just not happy. So
True.
it's tough. Yeah, yes, I don't miss it that much, so that's why I turn more towards these sort of advocacy and other things, like, I think that's where I can help out, but those are some of my thoughts. You
And
mentioned you mentioned the nasal IgG before
yeah.
we started
Yeah.
recording this, right? And so, hey, that's great, let's take a look at these things, let's take a look at that. I'm talking to a group here that's affiliated with, UCSF, and they I need to get back to this guy, but, they are finding ways of first of all, drawing blood without using a needle, just using vacuum, the
Like
blood
back of the arm? Or
yeah, yeah,
cool. So
yeah,
cool.
that's really cool. I'm like, "That's cool." Taking those samples, sending them in, and doing analysis on the RNA
Interesting.
and creating these pictures because the messenger mRNA,
Yeah.
which shows you what exactly is being transcribed, how often and what, and developing these. That's like proteomics and stuff like that. It's like looking at it and then correlating that with different disease states, right? Saying, "Oh yeah, this is what multiple sclerosis looks like. This is what," and looking at all
Yeah.
these immune related kinds of genes and saying, "Yeah, this one's activated. This one's not activated. This one's this interleukin is really high. This is not." All this stuff.
Mhm.
Looking at mRNA and then developing that for maybe for PAMs too and pandas, but they need samples. And that's why I need to get back to them.
And what's the name of that company?
I wish I could tell you. I am so bad with names. I am so
Uh-huh.
bad with but I do know that, they're very early, they're very new, so it may be too early to even, like, fully broadcast them, but they're I think those are the right directions, and I can send that to you later,
Okay.
I can
Sounds
find
good.
out.
I'd love to know. I'm really fascinated with mRNA because I
Alright.
think we've had such a even a direct to consumer emphasis on DNA, but we don't
Mhm.
live in DNA. It's kinda like the blueprint of the
Right,
house. Live in the blueprint, you live in the house, and that's really the
right,
house is built by RNA. Well, that
exactly.
really tells you what bricks to put, where to put doors and windows and
Very well said. You may not be turning on those DNA things, right? Yeah, it's the R
yeah.
right, but, so you don't know which ones are being used and which one are not, but the ones that are
Yeah.
being
So
used
the
are
mRNA is an interesting place of active research, for sure.
very cool. I agree, and, I will find that, and I will send that to you
Okay, thank you.
in my list of people to get back to. And we're doing great things. We're doing great things. I just, it's very early for some of these things, so it's always hard to know where you should be putting your eggs.
It's interesting. We've looked at a lot of those tests, for patients in our clinic. So we've looked at IOLO with the proteinomics. We're just getting into me screen with mitochondrial
Oh,
respiration.
okay. Yeah, yeah, mitochondria, so cool.
So cool. So cool.
You're awesome. I'm a
Yeah.
big fan of having good mitochondria.
That's a more we need more like mitochondria t-shirts.
I agree, I agree. You know, those are all good. Those are all parts of the body that are related at different levels, right?
Yeah.
I look at it at a more gross level, inflammation at a grosser level. It's all coming from these. It's from
Yeah.
proteins and from RNA transcription. Very cool, very cool.
Well, I think we've kind of talked about everything that was on our list. Uh,
Awesome,
is that
awesome.
true? I think that
Yeah, well,
might
the
be true.
last one that you wrote those is somebody is listening and wants to find care
Oh,
wherever.
yeah.
Yeah, yeah, you, very kindly give out my website, at the beginning, that's very kind, and
Yeah.
I kinda joke that I'm trying to lay low, but it's not because I'm not it's just because I can't, it's so
Yeah.
hard to do these things, right? Because now I'm no longer in a clinic with a rheumatologist or with a, pediatrician for an hour and a half. I'm here by myself trying to sort through 300 pages of these,
Right.
of this documents, but it's important and someone's gotta do it, and I enjoy it, and that's why I'm
Yeah.
doing this, and the problem is that there's not a whole lot of people out there who do that kind of thing, right?
Yeah. Absolutely.
Um, there are certainly, like I said, a lot of people now who are treating this internationally, and I think that's wonderful. So, to find those people, you could go to the, Pandas Physician Network, PPN. You can look
Mhm.
online and try to figure out, who's in your area and who's not. You can
Mhm.
go to the Pandas Network, Pandas Network, which was
Mhm.
started here in Menlo Park. They've been the longest advocacy group, and they
Mhm.
have a providers as well too. And, of course, you can always go on Facebook groups, but be very careful. There's a lot of, like, good information and misinformation on that because it's just
Yep.
coming from there, right? Right? So but you can, take everything you read with a grain of salt, question it all, but be open-minded at the same
Yeah.
time.
Absolutely. I absolutely agree. And the
Yeah.
websites that you were talking about, the Pandas Network and the PANS Pandas, is that the
Y
Panda?
yeah, Panda's Physician Network.
Yeah.
Yeah, physi
They have some really useful tools that can help you, even as a patient, they can help you as a parent kind of understand what to expect, and that might help you
Absolutely.
guide a clinician who might not be savvy or trained, but might be open and willing.
Absolutely, and the Neuroimmune Institute,
Oh, yeah. They are fantastic too.
they're fantastic. I'm working with them now too, just like volunteering, and Jenny Frankovich does a lot of talks for them. There's a cohort now with, like, almost 100 people who are getting training in this
Yeah.
area, which is fantastic, it's a training program, and they're getting training. So for providers who wanna get better at this, this is a great opportunity to do that
That's
and learn about all this stuff, and I'm doing it too, and I'm learning about a ton of things as I'm going along I'm just sort of like a support background person, but it's fantastic.
cool.
And you hear cases and things like that. So for providers, that's a great way of doing it. And
Yeah.
if someone's listening and wants to find care, they also do, and you have a very complex issue, you can ask your doctor to submit your case to
Oh.
panel, and then they will consider it, and then it may win the prize, and you'll have all these
Yeah.
specialists look at it, and it's
Cool.
fantastic opportunity to have your case in depth discussed and recommended.
Great. That's great.
Yeah,
All right,
yeah,
I wanna one more time mention your website, kikichangmd.com, KIKICHANGMD.com.
and that is not me on the surfboard, I wish it were. That's all.
I did wonder
People
that. I
people assume it's me, and I'm like, "I can't ride like that on these 30-foot waves, that's pretty tough." I can't even ride on 3-foot waves, so there you go.
no, it's a gorgeous picture, though. That's yeah.
Stock.
Thank you, and we love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together and are committed to sharing knowledge and insight that empower us and our communities towards greater health. Thank you for listening to the Neuroveda podcast for complex health, and we'll see you next time.